Hi, I'm Dr. Jessica Lilley, and I'm the Director of Pediatric Endocrinology at the Mississippi Center for Advanced Medicine. I'm in Tupelo, Mississippi, the birthplace of Elvis, and I'm here for a fireside chat with the Taylor Swift of Pediatric Endocrinology, Dr. Madhu Misra. We are having a little chat. I was talking to a lot of my colleagues and asked, who do you want me to talk to? Who do we need to hear more from? And it was a pretty unanimous choice. And so we're so excited. Everybody was really looking forward to asking questions. And so I get to be the filter for all of the thoughts that we were having. It's my joy to have this little catch up with you. I know we tried to talk at Endo and it was so busy and so loud and crowded that we're having to kind of try again with some of these questions. But I'm looking forward to kind of jumping back into that conversation. I want to let you introduce yourself and tell everybody kind of what you have been up to in your area of expertise and why we are about to be asking the questions that we're going to be asking about anorexia nervosa and its manifestations to pediatric endocrinology.
Oh, thank you so much, Jessica. I'm Madhu Misra. I'm the Chief of the Division of Pediatric Endocrinology at Mass General Hospital and the Talbot Professor of Pediatrics at Harvard Medical School. I'm a physician scientist, and much of my work and research has been in the field of neuroendocrine and bone alterations in conditions that span the weight spectrum from anorexia nervosa to the female athlete with amenorrhea to more recently obesity. But much of my early work was in anorexia nervosa and also in the female athlete with amenorrhea, so really functional hypothalamic amenorrhea, looking at the bone consequences and also possible treatment strategies. And I know that's what you want to talk to me about.
Yes. And so one thing that we all noticed during the pandemic was the startling rise of disordered eating, especially with anorexia nervosa. And so a lot more inpatient admissions, a lot more sequela during the pandemic. And so now we're all in the weeds trying to decide how to best take care of these teenagers and young adults that are coming to our care. And so, there's a lot that we read that, is best practice. And we know there's ivory tower medicine, and then we know there's rubber hits the road medicine. And I think we kind of represent both spectrums here, both ends of the spectrum, from all the way from Mass General to Tupelo, Mississippi. When I'm having these young people come into my clinic, I'm noticing, that we're, especially with the young women, that we are faced with, how to deal with the secondary amenorrhea. And then we are, putting them on transdermal estrogen. We're cycling with progesterone, doing all the things we're supposed to do. And then what? So that's kind of where we're stuck into thinking about, what are the things that we need to be thinking about when these young people come into our clinic? So what are some pitfalls that you notice when you're getting referrals from all over the country?
So thank you for sharing that experience. And certainly it's an experience that we're all familiar with, right? These are conditions that are really hard to live with, right? It's very hard to be a patient with functional hypothalamic amenorrhea. And it's very hard for the treating physician to know how best to help our patients that have the condition. The pitfalls are many, right? You can get bogged in so many areas. You can get bogged in, getting fixated on weight regain and menstrual resumption. And I think that is really, really important to emphasize, because the first step in managing functional hypothalamic amenorrhea really is to address the low energy availability state that characterizes, these patients, and work on optimizing energy availability. And that can be a long process. I'm not sure that a pediatric endocrinologist is necessarily the best person to do this on their own. Mm-hmm. I do think we need help from dietitians who have expertise in eating disorders. We need help from psychologists and therapists who have expertise in the field, because so I do a lot of rationalizing with my patients. I talk to them about the fact that this is a condition of low energy availability. I talk about how, when the body is in a state of energy deficit, it's going to shut down its reproductive axis because it senses that it's not the right time to bear a child. So from an evolutionary perspective, this makes a whole lot of sense that when you're in a state of energy deficit, you don't want to be growing a child inside you, right? A baby inside you. And so the reproductive axis shuts down. And so the best strategy to get the axis to start to work again is to get the brain to know that you're in a state of energy balance, at least, if not surplus. So that's really critical. The other component of functional hypothalamic amenorrhea that I think is less well appreciated is the issue around chronic stress that can also contribute to this condition. So while we're talking about caloric intake and exercise energy expenditure, I think it's very important to think about the stress that these young women are going through, and to be sure that they have the psychological support that they need to deal with that stress. So in addition to like I said, in addition to the pediatric endocrinologist and the dietitian, a psychologist or a therapist or a psychiatrist is really critical to that team. And we know that there are certain measures that help greatly. Cognitive behavioral therapy helps, family-based therapies help. And, I'm not a psychologist. I'm not going to spend too much time talking about this, but the team together can make a big difference. And when it comes to our athletes with amenorrhea, in those situations, the team is further extended to the coaches and the athletic trainers, because they have a big part in the athlete's life. And it's really important to have them be part of the team so they can really contribute to the treatment plan and be supportive of the athletes. And always, I think the parents have to be part of the treatment plan. And so when you have that large team of people working together with the patient, who's very much a part of the team as well, then I think you start to make some inroads into this whole process of helping the patients get better.
Right.
At the same time, I think we all know that it's not enough, that it's not always that when you fix or you try to fix all of these issues, and you can't always fix them, that menses will return. And that's when we start to get into, well, should we be starting transdermal estradiol with cyclic progestins? And why do we do that? What do we do before that? So, before we get to estrogen and progesterone replacement, I really want to be sure that everybody's calcium and vitamin D replete. We know that just getting calcium and vitamin D supplements are not sufficient to improve your bone density and bone health, but certainly it's important to optimize them. It would be silly to have a patient with a vitamin D level of 12 nanograms per ml that you started, estrogen and progesterone on, and not treating the vitamin D deficiency.
You have to have the raw materials, you have to
Exactly.
have the building blocks in place in order to build. So
absolutely, you need to be able to mineralize your bones, and you need calcium and vitamin D for that. And then, of course, you need to think about transdermal estradiol and progesterone replacement. Now, before we get to that, even I have long conversations with my patients about the impact of functional hypothalamic amenorrhea and also low energy availability per se on their bone health. And it can be it can be a wake-up call for our patients sometimes to realize that there is this impact on bone. Mm-hmm. And so I will get a baseline bone density on my patients that have functional hypothalamic amenorrhea. And I really spend a good 30 minutes in my first visit talking about the importance of the pubertal years in terms of bone accrual, mm-hmm. and the attainment of peak bone mass in the early 20s to the mid 20s, mm-hmm. and how having a low rate of bone accrual during puberty can lead to suboptimal peak bone mass, and what that means in terms of future bone health. In addition to needed bone health, if you're not accruing bone as you should. So there is that long conversation that I have. I talk to them about, why bone accrual is impacted. I talk about the importance of the pubertal hormones, certainly, estradiol and to some extent testosterone also, and that's important for bone health. And then also growth hormone and IGF-1 and their impact on bone health. So, growth hormone and IGF-1 are bone anabolic. Estradiol and testosterone are, anti-resorptive with some bone anabolic effects as well. Mm-hmm. And so I think, and then you talk about cortisol as well, which is made in excess, and that has multiple deleterious effects on bone. And I think for many of my patients, I see that when you talk about this in some detail, they start to get it, and they are curious about their bone health, and they are concerned about their bone health often. Not that it always fixes the issue, but again, I think it's important to have those building blocks in place in terms of developing that relationship and developing that understanding of what these conditions can do to you.
And you never know what's going to really speak to a patient and a family, and when you present all the future risk and all the things that can happen if we don't get the disease under better control, or if we don't get the care plan optimized, then you just are never sure what's going to really resonate. And I really love your analogy. You'd written a really wonderful article for Medscape a little while ago about how, these teenagers will come in with 70-year-old bones. And I think that's a powerful metaphor, that people can think about and say, gosh, like that's not something that I would want. Thinking about how this is going to impact, their skeleton for the rest of their lives, thinking about impact on fertility and just everything else that they're having to deal with. I think that's the bone health piece is a lot more powerful, I think, than we might imagine that it is.
And the other piece that I also talk about relates to some of the newer data we have regarding the impact of estrogen deficiency and its replacement on neurocognitive measures and issues around emotion and mood.
Right.
So we've shown that estrogen replacement has an impact on anxiety measures, for example. So there was one study where we showed that that girls with anorexia nervosa who received estrogen replacement had an improvement in trait anxiety, which is the tendency to be anxious over time. And we also showed that with weight regain, when you did not receive estrogen, there was an increase in state anxiety, or the immediate sensation of being anxious over time. But then if you received estrogen with weight regain, you did not really have that increase in state anxiety or an increase in body dissatisfaction that was seen with in the absence of estrogen. So there's an impact on anxiety. There's actually it seems to be an impact in eating behavior per se. So drive for thinness gets better, body dissatisfaction, as I said, gets better with estrogen replacement. And it seems that estrogen deficiency, does the converse. It kind of is deleterious potentially to these measures. So I do talk about these issues as well. And again, it depends upon the individual, what's going to resonate with any one person. It's hard to tell, whether it's bone, whether it's the neurocognitive issues, whether it's the eating behaviors.
Mm-hmm. Well, and then, estrogen is a powerful hormone. And so it's one of my very favorites of all the hormones. I love them all, but, you think about all the many impacts of estrogen. And so a lot of times, we know that these multidisciplinary services are so important. And it's the treatment has to come from so many different directions. And I think for those of us that are out here kind of by ourselves, it can feel very overwhelming. For me to send to a sports nutritionist, I've got at least an hour a drive, have patients who are economically disadvantaged. I think even the readiness to accept a diagnosis of an eating disorder is really difficult for a lot of patients in rural areas and everywhere. I think it's, a diagnosis around which there's a lot of denial sometimes. And so trying to realize that we're not alone and that we can't do it alone and shouldn't try to do it alone is really important. And so as these young people come into our clinics, a lot of times they won't come with an eating disorder label, on the referral. They'll come in with slightly abnormal thyroid function testing or rapid weight loss. And then a lot of times we don't even know we're walking into this kind of room. And so I think it's important for us to always keep it on our radar that this is something that can present, and that we can even see some like energy deficit and some malnutrition in children whose BMI are not even all that low. And so, really kind of getting a good sense of that history and what kinds of nutritional measures are coming in and what kind of quality of the caloric intake they're getting is. I think sometimes it can come in a lot of disguises. So any thoughts on that or?
Yeah, I think, Jessica, you bring up a really good point, and that is, there is anorexia nervosa, frank anorexia nervosa, as we know it, associated with low weight and, the eating behaviors that are associated with the condition. But then there is there's atypical anorexia nervosa, which is very much part of the DSM-5, categorization of eating disorders. And atypical anorexia nervosa refers to the kind of patients you just mentioned, right, who lose a lot of weight, but they're still within the normal range for weight and BMI. And you would think that because the BMI is okay, that they're probably okay, and they're not. And we've actually, we just submitted a paper that shows that that young women with atypical anorexia nervosa also have low bone density, not quite to the extent as in typical anorexia nervosa, but still pretty low bone density, and a large proportion of them have low bone density Z scores. So it is really important to pick up atypical anorexia nervosa as much as it's really important to pick up anorexia nervosa that's typical.
Right. I'm becoming concerned. I rejoiced when the first AAP guidelines came out that urged GLP-1 receptor agonist use in children. And I've dealt with, the number one most years in pediatric obesity is my state. Sometimes we'll drop to number 3, but it's a chronic problem here. And Mississippi Medicaid has just made the decision, and I think it's really, groundbreaking to make sure that we cover with, prior, authorization and proper patient selection. But we're going to have a lot more children on GLP-1 receptor agonist. And so I'm excited about it. We finally have something that will work. We're going to, make all kinds of, measures better for these children. But I'm really worried about empowering disordered eating and malnutrition or poor nutrition. And as we're kind of following these, I think that, keeping that in mind and really, walking through with patients and especially in places where we don't necessarily have a psychologist or nutritionist or someone else to help us, I think we all need to bear that in mind. Do you share these concerns for these medications?
Oh, yes. I think there are major concerns regarding the emphasis on weight loss in general. And, I think it's important to be worried about obesity and to think about how to manage it appropriately. But, my psychology colleagues tell me that they are seeing a lot more eating disorders that happen in the course of people with obesity losing weight.
Yes.
Suddenly. So that's certainly a thing. And I remember doing a talk, a plenary talk for, I think it was the ICED or the EDRS, one of the eating disorder societies. And a lot of the questions I actually got related to weight loss and obesity and the association with eating disorders. So it is a concern. My psychology colleagues tell me that it's very important to have, to see if we could actually loop in psychology when we're treating patients with obesity who are going on these very powerful medications that cause this extended weight loss. And I completely understand that it's very hard to get behavioral therapy or psychology support in many parts of the country. And, we're really blessed being here in Boston. But I wonder whether there's a way to engage other kinds of providers who can provide some of the support, so are there social workers who have an interest in the area who could be looped in to help with patients who are dealing with body image issues as they lose weight. I think it's important to figure out a way to get them that support. Right. It would be great if we could provide them with that support, but I don't want to presume that we can because we're also busy in our clinics. Right. And we have so little time for the patient visits that, these are really long conversations, and it takes a fair amount of skill to, to detect the emergence of eating disorders and to manage it, appropriately.
I think we just have to keep our eyes and ears open as we're going into these encounters and realize that that there are pitfalls and and different things that we need to be aware of, rather than saying, oh, I can't do it, I don't have anywhere to send them, whatever what am I going to do, but to realize that if we're sensitive and we are looking out for things, and we can make sure that we don't cause harm to patients while we're trying to help them.
One of my colleagues who runs the obesity pharmacotherapeutics clinic, she has been having some extensive conversations with my psychology colleagues regarding this issue. So there are questionnaires you can have patients fill out on an ongoing basis. That might be helpful if you are an endocrinologist by yourself to help determine whether some of these behaviors are emerging that could be addressed early on.
Right, before they become really problematic.
Exactly.
So one thing that we also, notice is as we're, taking care of patients who are in recovery or active treatment for eating disorders, is we see other hormone axes that are affected. And so thyroid is one that we often will see almost like a SICU thyroid pattern at the beginning, and then we'll see the TSH bump. And then, what do you see as you follow these patients long term? When do you start to worry? Like how quickly do you expect the thyroid to kind of adapt to the improvement in BMI and as they start to regain weight and restore healthy body mass?
Yeah, and this is a very good question, and it's a really difficult question to answer because it's so variable from patient to patient, right? The rate of weight regain is variable. People can gain weight, lose it again, that they can be, remissions and exacerbations of the eating disorder. And everybody's thyroid axis is just a little different in terms of, how that recovery occurs. I think it's important to recognize that that there will be thyroid hormone, or there can be thyroid hormone abnormalities in patients who have eating disorders and as they recover from them, and to know that if there are subtle abnormalities in the TSH level or the T4 levels, that that it's important to think of a CQ thyroid kind of picture first before jumping to any other conclusion. Now, if you have a slightly elevated TSH with a lowish free T4 or a low T4 free T4, that's unlikely to be primary hypothyroidism, right? You would expect the TSH to be definitely quite elevated for the free T4 to be low.
Right.
But if there is a patient that you're really kind of confused about, go ahead and get the antibodies, just buy yourself some time. If the TSH is just a little high and your free T4 is a little low, not treating for some time is not going to do any harm.
That's right.
Whereas treating could do some harm for sure.
Absolutely. Yes.
So I'm always very hesitant to think of these subtle thyroid hormone abnormalities or TSH abnormalities as anything more than something like a CQ thyroid syndrome in patients who have these eating disorders.
Right. And so anything else that you're thinking of as you're seeing these patients? I know, if they're coming in worried about rapid weight loss, as we're trying to work through to get to the bottom of the diagnosis, we're often screening for Addison, screening for celiac, other things that can cause, kind of sneaky weight loss. Anything else that you're thinking of as an endocrinologist when you're seeing these patients? You mentioned growth hormone deficiency. I know we're seeing younger patients who are having eating disorders. Is there any kind of scenario in which that you would actually treat with growth hormone, or would you just, again, really focus on healing the eating disorder and restoring body mass?
Yeah, I would really focus on treating the eating disorder and restoring body mass, because they have a state of growth hormone resistance, actually, not so much deficiency, because they have low levels of IGF-1 and robust levels of growth hormone. And also, when you give growth hormone in pretty high concentrations to women with anorexia nervosa, it just causes a little bit of a bump in IGF-1 levels that's not statistically significant. So that seems to be, so it's really not helpful, at least from a bone standpoint. So we did a study where we gave supraphysiological doses of growth hormone, so 5 to 6 times replacement dosing to adult women with anorexia nervosa. And there was no significant increase in IGF-1 levels or in bone formation markers. There was a little bit of a bump up, but nothing that was really significant. And what was really concerning in the study was that the women who received the high growth hormone doses lost fat mass. So really and that makes sense, right? Because growth hormone is lipolytic, but certainly not what you want to see in the condition. They didn't have weight loss, but they had fat mass loss. Again, not a great outcome. But there are some data out of France, and this relates to younger girls with anorexia nervosa who have an impact on height from being undernourished. And they showed that giving growth hormone can help improve height outcomes. Now, when we looked at height outcomes in our patients with anorexia nervosa, our participants with anorexia nervosa in the studies that we did, we actually did not find an impact on height. But that's probably because our patients were, definitely, I would say, in the 12 to 18-year age range when they were diagnosed. And so a lot of their growing had been done, by the time they were diagnosed with a condition, as opposed to the cohort from France, where the girls were much younger, and therefore, there was an impact on height.
Right.
And it was interesting that they responded to growth hormone. So, you have to think about potentially the effects of growth hormone on the growth plate versus the osteoblasts and osteoclasts, and whether there's a difference in terms of how, growth is impacted versus how bone is impacted. So it's all very interesting.
It's fascinating. We have the very best discipline. I mean, you think you get one thing figured out, but there are a lot of other cascades going on in the background. So,
there are all the appetite regulating hormones that are so interesting, that are that kind of go awry in these eating disorders. And some of them kind of make sense, and some of those changes do not make a whole lot of sense.
Some of them are kind of paradoxical. So, and trying to unwind them and keep up. So. I know one of my biggest challenges, I get the female athlete triad in my clinic a lot. And so we work on trying to get the calories up and get the activity down until we can get everything going. But then while we're trying to restore menses, and we do start transdermal estrogen and progesterone, how long do you treat, and what measures do you use to be able to say, okay, let's withdraw this therapy and see, if we're doing okay. Let's say that my DEX is improved, we haven't had pathological fractures, and we have a young woman who's on her way to healing. When do you feel comfortable, withdrawing the supplemental estrogen and progesterone?
So a lot depends upon how the patient is doing in terms of recovery from the underlying condition, right? And so if a patient is able to bring her weight to a healthy point and keep it at that healthy point for several months, I think it's reasonable to give the patient a trial of transdermal estrogen and the cyclic progestin to see whether they will resume menses on their own. Now, even before we get to this, the one point I do want to make is, as girls and young women regain their weight, there can be a lag period before they get their menses back. So there was a study by Neville Golden's group from Stanford, where he showed that it can take several months of being at a healthy weight before menses resume. So sometimes you might just want to be a little patient and give the patient a few months before you consider starting transdermal estrogen, particularly if the patient is in a good path towards optimal weight regain. The other thing that he showed, so Dr. Golden showed in that study, was that on an average, the girls with anorexia nervosa who regained menses had a body weight at the time of menses recovery that was about 2 kilograms greater than that at which menses were lost. So, when you think about the target weight that you were aiming for, you need to think about what the weight was at the time of that menses were lost, in addition to thinking about, the 90% median BMI that we kind of aim for. It's important to think about the weight at which menses were lost and aim for something that is above that weight.
Mm-hmm. And that's important to know. And having these parameters in mind are very helpful to us. And so one thing that we discussed before, and this is something that I think a lot of us kind of have passing thought about, but don't really think about the science because we get busy or we've forgotten it and it's been too long. But I know a lot of times these young women are at the age where they're starting to think about contraception. And so we might think, aha, I'm going to supply a contraceptive patch. Tell us why that's a bad idea.
So I'm going to first talk
about suboptimal idea.
I'm going to first talk about the contraceptive pill and why that's a bad idea. And when we think that, by this time, we all know that combined oral contraceptive pills do not improve bone density in young women with functional hypothalamic amenorrhea. I still get patients referred to me who are on the birth control pill for bone, mass increases and not for contraception. So that's problematic. And I think it's very important to recognize that being on a combined oral contraceptive pill can do two things. One, it doesn't help your bones. Mm-hmm. Two, it can take away the indicator of menstrual recovery, because it can be very reassuring to have regular menses on the birth control pill. And to feel that you're probably doing okay for your reproductive axis. So that's kind of really important. Transdermal estrogen is effective in improving bone health, whereas the combined oral contraceptive is not, because of many reasons. One is because when estrogen is given orally, particularly as ethinyl estradiol, which is the kind of estrogen we have in the birth control pill, that suppresses IGF-1 because of hepatic first pass effects. And this does not happen with transdermal estrogen. Also, transdermal estrogen, which is actually transdermal 17-beta estradiol, that's what we use in hormone replacement therapy in this condition, that will not increase sex hormone binding globulin levels, whereas the combined oral contraceptive pill will, and quite dramatically. And so that would lead to a decrease in bioavailable gonadal steroids. And then there are other hormones that are impacted by the route of estrogen administration, such as chlorostin and pre-adipocyte factor 1, BDNF, and they all have an impact on bone. So it's important to recognize that the route of estrogen administration is important. Now, in a woman who needs contraception, that is really important. And we need to think about what kind of contraception would work in this situation. So the birth control pill, of course, works. Combined oral contraceptives work. And if that's the only form of contraception that is going to be something that the patient can work with, and is comfortable with, I would say, do not withhold that. But it's important for them to recognize that this is only being given for contraception, and that is not going to have an impact on bone health. At least it's not going to improve bone health.
Right.
With regards to the contraceptive patch, so the contraceptive patch, like the pill, has ethinyl estradiol. It does not have 17-beta estradiol. And we really do not have good studies at this point of time that tell us what transdermal ethinyl estradiol with progestin does to IGF-1 levels, to sex hormone binding globulin levels, and to bone markers and bone health in general. So we are in need of those studies. It may be that they will be more effective than combined oral contraceptive pills. If I had to guess, I would say that the efficacy would probably lie between a combined oral contraceptive pill and the transdermal 17-beta estradiol patch in terms of bone efficacy.
And thinking through too, and the rest of the patients that we treat, say the young women who come in with PCOS, or when you're choosing the dose of estrogen that you're putting in these combined contraceptive pills, do you tend to lean toward a higher estrogen dose, just thinking about bone health? I know a lot of times our general pediatrician colleagues will come in and pick the lowest estrogen they can, and to me that just feels wrong. I feel like when you're in that kind of main period of bone accrual, that I would tend to lead toward a higher estrogen, like maybe more like a Sprintec rather than a low estrin, and just and making sure, and to not to mention the breakthrough bleeding and everything else that we see with the lower doses. Is that something that matters to you as a bone expert?
I just don't think the combined oral contraceptive pill does much at all, because we have used the 30 microgram combined oral contraceptive pill as one of the comparison arms in the studies looking at transdermal estrogen, and 30 micrograms ethinyl estradiol did nothing. Catherine Gordon's group has looked at the 20 microgram ethinyl estradiol pill, and that did not do anything either. So, there are different opinions regarding what dose of ethinyl estradiol may be good for bones in women with functional hypothalamic amenorrhea. So like you mentioned, some people will think that maybe a higher dose is more effective. And then there are others who feel that maybe a higher dose is not more effective because there's a greater effect on IGF-1 and sex hormone binding globulin levels. So it's tricky. And overall, neither the 20 nor the 30 microgram dose seems to work. We haven't used the 15 microgram dose, for example, and in functional hypothalamic amenorrhea. There are some comparative studies in normal weight healthy people. But those are difficult to extrapolate to this particular condition. So, I just say that they're not going to be effective.
Right. So don't think about the bones so much, but think about all the other things that we need to think about when choosing the dose to start the young women on.
Right. So, if you're thinking about everything else, just go with what you would do in a typical situation. But I would not expect that to have I wouldn't expect the decision to necessarily to be impactful for bone in any particular way. Now, there was a study by Anne Klebansky many years ago, and this was in adult women with anorexia nervosa. And in that study, she showed that the very, very low weight women did seem to have some benefit from being on a combined oral contraceptive pill. So this was a post hoc analysis, and it was the really very low weight women. And in that study, there seemed to be some effect. But in our studies, we've really not seen an effect. Even when we looked at weight status.
Right. Well, and that's very helpful to know. Shifting gears, I'm thinking about our young men, and so we are definitely seeing young men who are coming in with eating disorders and who are having impact on their own bones, and they don't have the red flag of menses to let us know how things are happening for them. And so, what are your concerns when you take care of young men with anorexia nervosa or other low weight eating disorders?
Yeah, you're so right. Without that biological indicator of menstrual status, it can be so difficult to have an early diagnosis, and also to know, what's recovery, right? So one of the differences in terms of males and females with eating disorders is that many a time the men who have eating disorders or the boys with eating disorders may not be low weight. It's just that they have very low fat mass. And we talk about the drive for muscularity scale as something to assess in young men as opposed to the drive for thinness that we look for in young women with functional hypothalamic amenorrhea. So there are many issues. One is that we don't have that indicator of menstrual function. The second, with regards to the reproductive axis, is that unlike women, whose reproductive axis is very sensitive to energy deficit, the male reproductive axis seems to be fairly resilient when it comes to its responsiveness to energy deficit. And it seems to take a lot more of an energy deficit state to lead to hypergonadism and low testosterone levels in young men with eating disorders than we see in young women with eating disorders in terms of the estradiol levels and menstrual function in general. And so there's been a lot of thought into, what do we think about, what kind of testosterone levels do we think are concerning in young women that we think have eating disorders or do have eating disorders? Are we looking for really low testosterone levels, which we can find in certain situations? And I've certainly had patients that had very low testosterone levels, but many will have lowish testosterone levels. And so, that is also kind of important to consider in the context of, body composition and maybe frank body weight changes over time.
Right.
And the other issue that I'd mentioned briefly before was, as you work with these young men in terms of optimizing energy status and weight regain or fat mass regain, when do you know that you're at a safe place? So we just did a study, published a study in young men with young athletes, so male athletes who are runners. And we found that in that study, and it was a small study, so you need much larger studies to really validate these findings, that a BMI of even 21 was kind of a differentiator in terms of who had low bone density and who did not. So, that's not something that you would typically think of as your demarcator in a sense, right? Mm-hmm. So we're thinking of a BMI of 18.5 or such, but then, is that uniform across men and women, and so there are many, many unknowns when it comes to how we diagnose eating disorders and how we manage them, and what are the indicators of recovery and adequate recovery in young men with eating disorders. They certainly have low bone density, can have low bone density. Young men that have frank anorexia nervosa do have pretty low bone density. Young male runners who may be in a state of energy deficit are not impacted to as great a level as those with frank anorexia nervosa.
I feel like every time I talk to you, I've learned something new, and I want to go read and learn some more things. And so I appreciate the light that you're shining in our field on all these important issues and the way that you're encouraging others. Thank you so much for your time.
My pleasure, Jessica. Thank you. And thank you for asking all these important questions.